Welcome to The Coalition. This is a talk show dedicated to discussing health, wellness, and inspiration. I'm your host, Dr. Shani Belgrave.
Hello, everybody. Welcome to The Coalition. I'm your host, Dr. Shani Belgrave. I am a minimally invasive and bariatric surgeon in Atlanta, Georgia. You can learn more about me and get connected at www.drshanibelgrave.com. I am grateful and excited to have on the show today Dr. Michelle Glasgow. Dr. Glasgow is a gynecologic oncologist who's here right on time for Uterine Cancer Awareness Month to let us know what we should know about endometrial cancer. Dr. Michelle Glasgow, thank you so much for joining the coalition.
Thank you for having me, Dr. Belgrave. This is an honor.
So, listen, Dr. Michelle Glasgow, I know that this is going to be an impactful episode, but before we get into it, I just have to share something with our viewers. I need to let our viewers know that Dr. Michelle Glasgow and I were actually schoolmates. We both did our undergraduate studies and medical school at Brown University. So from Providence to Atlanta, it's a full circle moment, which makes it even more special that you agreed to come on the show.
Truly.
All right, Dr. Michelle Glasgow. So can you please get us started by telling us a little bit about who you are and what you do?
Yes. So I'm originally from New Jersey, and I have traveled and lived throughout the states. I was in Rhode Island, as you mentioned, for college and medical school at Brown. And then I went to Yale. I was there for my OBGYN residency program. And then I did fellowships both at Emory and at the University of Minnesota in Minneapolis. And now I call Atlanta home. I've been practicing at Northside Cherokee in Canton for nearly 8 years. And when I'm not there, I love spending time with my family, my husband and my 2 daughters who are almost 6 years old and 3. They're just my everything.
So fantastic. Well, that makes this even more special because I know you had to carve some time out of a very busy schedule to be here with us.
It's a pleasure.
So, Dr. Michelle Glasgow, can you kind of give us some education on what conditions does a gynecologic oncologist treat?
So as a gynecologic oncologist, I take care of women with gynecologic cancers, so endometrial cancer or cancer of the uterus, which we'll talk mostly about today. Also cervical cancer. I also take care of women with ovarian cancer, fallopian tube cancer, as well as a condition called primary peritoneal cancer. Primary peritoneal cancer is cancer of the peritoneum, which is the lining, or one can think of it as the wallpaper of the abdomen and pelvis. But ovarian cancer, primary peritoneal cancer, fallopian tube cancer, they're all lumped together within one condition as they often present the same way and they're treated similarly. I also take care of cancer of the vulva or the labia, as well as vaginal cancers. I perform surgery for women with these cancers, and then I also administer chemotherapy for women with these cancers who need chemotherapy and live close to my office. I also perform surgery for women who don't have gynecologic cancers, but may have more complex conditions. So for instance, women who have large fibroid uteri, women who have a mass which may appear benign, but they may have a very complex surgical history such that their surgery may be more challenging. I also perform surgeries and take care of women with these conditions as well.
Wow, that's incredible. So can you give us a little bit of education on the scope of the problem as it relates to endometrial cancer? How common is this condition?
Endometrial cancer is unfortunately on the rise. Compared with all the other cancers which affect women, it is not as common as other cancers. So only about 3 to 4% of women will develop endometrial cancer, but it is the most common gynecologic cancer that is out there amongst all the other cancers, which I mentioned, which I take care of. So over 66,000 women will be diagnosed with endometrial cancer every year. And this is the first year ever where the number of deaths from endometrial cancer are outrunning the number of deaths from ovarian cancer. Ovarian cancer has typically been considered to be the most aggressive, the most lethal gynecologic cancer, but that is now changing, whereby endometrial cancer is unfortunately taking the lead.
Any thoughts on what's accounting for that change?
I think the biggest reason is the obesity epidemic. Obesity is the number one risk factor, as well as being overweight, number one risk factor for endometrial cancer. And unfortunately, we are finding that more and more women are being diagnosed at higher stages where the cancer has spread beyond the uterus. And we are also finding, and the reason for this is unclear, but we are also finding that among Black women especially, the numbers of new endometrial cancer diagnoses are skyrocketing, and Black women are also being diagnosed with the more aggressive forms of endometrial cancer. The reason for that is unclear, and that is an area of great research.
Wow. When I see patients in clinic regarding obesity and weight loss surgery, I often share education that obesity is a risk factor for many problems: high blood pressure, diabetes, cholesterol, and certain cancers. And as you said, there is that unfortunate link between obesity and endometrial cancer. But I'm hopeful that as we get a better handle on the obesity epidemic, that hopefully that trend that you're seeing will start to go the other way.
Yeah. I'll say that unfortunately, many women, when they think about the different health conditions that are associated with being overweight and obese, endometrial cancer does not come to mind. I often meet women who said they've never heard of this cancer until they've been diagnosed with it, because unfortunately there just isn't as much publicity, I feel, given to this cancer compared with other cancers like breast or colon cancer. So that's especially why I'm very excited to talk about this cancer today, just to let women know that this is out there, as well as another motivator to encourage them to get healthier.
Absolutely, because education is power, and the goal of this show is to really help transform lives. I'm really grateful that you're here right on time for Uterine Cancer Awareness Month, so we can really try to get this information out.
Absolutely.
So, what are some of the signs and symptoms? I was thinking about this because a lot of women were getting routine preventive screening, mammograms, pap smears, but how would one find out that they have endometrial cancer?
So unfortunately, there is no way to screen for endometrial cancer the way there is for breast or colon cancer. Endometrial cancer typically has been considered to be a cancer of postmenopausal women who are no longer menstruating, but we are seeing endometrial cancer occurring more and more in younger women of reproductive age. But the biggest risk, or the biggest sign or symptom of endometrial cancer is abnormal bleeding. So for women who have gone through menopause, any spot of blood could be a sign of endometrial cancer, and it's often, unfortunately, mistaken for something else, which can lead to delayed diagnosis. So, for instance, some women may notice some spotting or some blood when they're wiping, and they may think it's a UTI, and then they undergo this workup for evaluation of UTI, and then finally, when that is ruled out, then they're sent to see their gynecologist. So the most common symptom in postmenopausal women is just any bleeding, whether it's one episode of bleeding, and certainly anything that's heavy like a period. But in younger women, any change in their menses can be a sign of endometrial cancer. So if a woman is starting to bleed in between her periods, or if her periods are suddenly much heavier than was previous, and especially if she's overweight or obese or over the age of 40, or all of those should all be all be signs that should alert a provider that they should be evaluated for endometrial cancer. There are other signs of endometrial cancer, but those are less common signs. So, for instance, if a woman is now experiencing some new pelvic pressure or pain or changes in bowel movements or urinating, that could signify an endometrial cancer, but usually one that has advanced beyond the early stages. I always encourage my patients and their family members who ask me about what can we do, or what should we look for, and really anything that is outside their norm, especially any bleeding, any new bleeding, or any change in bleeding patterns, but anything that's outside of their norm, especially in terms of any discomfort in the pelvis or changes in bowel or urinary function, should alert them that they should see their gynecologist and get evaluated, because it could represent endometrial cancer or another gynecologic cancer.
And so, what does that workup include? If someone goes to seek care because they have these changes in their menstrual cycle, then what would the workup include?
The workup first includes obtaining a pelvic ultrasound to evaluate the lining of the uterus to see if it's thicker or not, and then an endometrial biopsy, which is typically performed in the office, but sometimes it's performed under anesthesia as well.
And so, is this something that a woman's gynecologist can do, or would they, because it's diagnosed before they come to see you, right?
Most times, but sometimes patients are sent to see me just because they are bleeding, and then I'll do the evaluation as well.
Okay.
They're usually sent to see me either from their primary care doctor or their OBGYN who will perform the ultrasound and the biopsy, and then either their primary care doctor, or sometimes they'll just go to the ER because they're bleeding. They'll then send them on to their general OBGYN first.
Okay. Wow, this is really good information. So, I know we talked about obesity being a risk factor. Are there other things that we can do to reduce our risk of developing endometrial cancer?
I will say that obtaining a normal BMI is the biggest thing that one can do to modify their risk. There are other risk factors, though, but they are not as easy to modify. So, for instance, there is a condition, a hereditary condition called Lynch syndrome, which is a genetic syndrome which puts patients at high risk of endometrial cancer. So with Lynch syndrome, a woman's risk of endometrial cancer is 40 to 60%. It is also associated with an increased risk of colon cancers, ovarian cancer, and stomach cancer. And while there's nothing that can necessarily be done to first identify this, I'll say that I think knowing your family history is really important. So, for instance, if you know that you have this syndrome, then there's a lot that can be done, but it's first knowing your family history. So if you have multiple family members who've had colon cancer or endometrial cancer, especially under the age of 50, and there isn't anyone who's been diagnosed with a mutation, I think that for such a woman, she would be in a scenario where it would be very reasonable to consider undergoing genetic testing to see if she has one of the mutations associated with this syndrome. The reason for that is if she's diagnosed with this syndrome, then she could consider enhanced screening for endometrial cancer with pelvic ultrasounds or serial endometrial biopsies, or even undergoing a risk-reducing surgery, essentially a hysterectomy, when she's completed childbearing to prevent this cancer from forming. And then also, if she's diagnosed with Lynch syndrome, she would undergo more frequent colonoscopies to screen colon cancer. So that is one way to reduce one's risk, but simply I would start with just knowing your family history of cancer, asking questions, and then if you have any concern, or if you notice multiple members with one particular type of cancer or two particular types of cancer, undergoing genetic testing. The other thing that increases a woman's risk of endometrial cancer is also just anything that leads to high levels of estrogen. So, for instance, patients who are on, and this really almost never occurs nowadays, but there are some patients who have not undergone a hysterectomy and receive high levels of estrogen in the form of hormone replacement therapy. If a woman has not undergone a hysterectomy and she receives hormone replacement therapy when she enters menopause, she really should receive both estrogen and progesterone. And the progesterone, the goal of that is to counteract the effects of the estrogen to prevent uterine cancer from forming. If she receives only estrogen, then she is at a high risk of developing uterine cancer. So I think just being aware of what you're receiving and asking questions to your doctor when you receive medications like this, will this put me at a higher risk, is important.
Well, that's really fascinating. I was just thinking about what you were stating about the estrogen and hormone replacement therapy. And in your medical opinion, what do you think about hormone replacement in postmenopausal women? Do you think it's safe as long as they're also getting progesterone, or do you think it should be limited for the shortest amount of time possible? Or what are your thoughts on that?
I do think it's safe for a limited amount of time. But I think that it's really important that women know exactly what they're receiving.
Mhm.
And especially if they have not undergone a hysterectomy, they should be receiving both estrogen and progesterone. I will say there are lots of different formulations of hormone replacement therapy that are now available. And sometimes it's unclear what women may actually be receiving, what proportion of hormones they're receiving. And I think that it's just very important to always be aware, because if there's an imbalance between those, amongst those hormones, then you're at a higher risk of developing some hormone sensitive or hormone receptive cancers. But I do think it's safe for a limited period of time. But I think it's really important that women know exactly what they're receiving.
Wow, so much to think about there. Because I know that's a common thing patients ask about is management of hot flashes and other perimenopausal symptoms. And so just want to make sure that we're giving patients the safest and the best information. So
What I'd like to add though is that if a woman is not a candidate for hormone replacement therapy, there are many other options out there which can be effective in managing whatever symptoms they have. But it's always a discussion.
okay. You talked about how you do surgeries to treat endometrial cancer along with other cancers. Can you kind of give a little bit of information to our viewers about what that entails?
So for endometrial cancer, first, minimally invasive surgical techniques have um, really become the primary approach to surgery for patients with endometrial cancer. So when I say minimally invasive surgery, I mean laparoscopic robotic approaches to surgery where patients have a few small incisions and the recovery is a lot quicker compared with an open surgery where they have like a large up and down vertical midline incision. What surgery will typically entail will be a hysterectomy. So that's removal of the uterus and the cervix. I always specify that because a lot of women will come to me and say, oh, I've had a total hysterectomy. And they think that they had their ovaries removed as well. But that is actually another procedure which is often performed at the same time. So removal of the ovaries is described as an oophorectomy. But I always just list out to my patients exactly what I'm removing. So hysterectomy, removal of the uterus, cervix, fallopian tubes, a salpingectomy, and then for women who have gone through menopause, removal of the ovaries, oophorectomy. I will say that for younger women with a diagnosis of endometrial cancer, there is the option, if it appears that they may have early stage disease where their cancer is not spread outside the uterus, where the ovaries can be left in place so that they can have continued hormonal support. But again, that is always a discussion of the risks and benefits. But a typical surgery for endometrial cancer will include removal of those organs plus evaluation of the lymph nodes. We'll typically evaluate the lymph nodes by a procedure called a sentinel lymph node mapping procedure. So what that means is at the very beginning of the surgery, I inject a dye into the cervix, which travels through the uterus to lymph nodes where the cancer could spread. And this dye causes the lymph nodes to change color. And then during the surgery, I'll perform a biopsy and remove the lymph nodes which change color. And the lymph with the dye. The lymph nodes which change color does not indicate the presence of cancer. The only way to know where the cancer has spread, if it has spread outside of the uterus, is once all the tissue goes to pathology and is examined there. But that dye, that going to that first lymph node, just allows us to do essentially a little bit less surgery. We remove fewer lymph nodes, but get the same amount of information that we would receive from removing all of the lymph nodes that could be affected. And then there's less risk associated with removing fewer lymph nodes, and it can be sometimes a shorter surgery. With robotic surgery, my patients will typically spend one night in the hospital, and then I'll see them 2 weeks after to go over the pathology, and the recovery is generally a lot quicker. And then based on the pathology and the stage, so is the cancer in the uterus or is it spread beyond the uterus? And are there any other risk factors within that pathology report which could indicate that the patient is at a higher risk of the cancer returning? Then I will make a final recommendation if they just go into surveillance, which means just coming in for routine visits to monitor for any signs of the cancer returning, or if I recommend radiation or chemotherapy or immunotherapy after surgery. So for surveillance, that generally will mean that a patient will come into my office every 3 to 6 months and we'll monitor for any signs of the cancer returning. So that could mean any vaginal bleeding or discharge or any new abdominal pain or changes in bowel or urinary function or anything really that's outside of their normal. And then we perform pelvic exams at each visit. Generally, I'll only perform scans like a CT scan or a PET scan if there is something concerning that the patient reports to me, or if there's something concerning on my pelvic exam.
Whoa, well, this was truly educational, Dr. Glasgow. I learned a lot.
Yeah.
So I'm grateful that you came on and really, in a short amount of time, gave so much really good information that I know is going to transform lives. What is the best way for viewers to connect with you if they have had any issues and they need a consultation?
Yes. A lot of patients will be referred to me either from their OBGYN or their primary care doctor, but patients will also just call our office to schedule an appointment. Our office number is 770-721-9400. And as I mentioned, I'm happy to see patients with new diagnoses of gynecologic cancers or women who don't have cancer but may need a more complicated surgery. But I also see women for surveillance, women who were diagnosed and treated for cancer at another facility or in another state and have moved closer to my office and need to see a gynecologic oncologist just for routine visits.
Phenomenal. Well, thank you so much, Dr. Michelle Glasgow, for joining the coalition.
Thank you for having me.
Today, we talked about endometrial cancer. I'm hopeful you'll come back another time to talk about another area of your expertise.
I would love to. Thank you so much, Dr. Belgrave.
Thank you. Well, everybody, thank you so much for tuning in. That was a really impactful episode. Thank you so much to Dr. Michelle Glasgow, gynecologic oncologist. So grateful she was here to come on the show to spread awareness for Endometrial Cancer Awareness Month. You can also connect with me at www.drshanibelgrave.com. I'll see you next time.